This is a discussion of lower extremity nerve blocks and chemodenervation under ultrasound guidance. This is also a companion for those of you who went through the workshop at AANEM. Listed are some of the positives and negatives of doing procedures under ultrasound with Botox. We will start with looking at the posterior ankle and leg, including the Achilles tendon, medial and lateral gastrocs, and the soleus muscle. Start with evaluation of the Achilles tendon and then move proximally to look at the Achilles tendon above the soleus muscle and Kager's fat pad. And now with the transducer and short axis, we can see the soleus and the medial and lateral gastroc muscles. The medial ankle evaluation in short axis becomes the foundation for looking at the deep posterior compartment. From anterior to posterior in this view, in short axis we can see the posterior tibialis, the flexor digitorum, the nerve and vascular structures, as well as in the most posterior aspect the flexor hallucis longus. Dynamic movement on the right reveals the flexor hallucis longus and the flexor digitorum. We move more proximally across the ankle to the leg. The orientation of the posterior tibialis and flexor digitorum communis will be switched. Evaluation of the posterior compartment in short axis is shown above. This is a short axis distal to proximal scan along the tibia, and it shows the posterior tibialis tendon moving counterclockwise and under the forming muscle of the flexor digitorum communis. In the short axis view, the soleus is seen superiorly and the tibia is to the left with the flexor digitorum longus in the middle, and on the bottom is the tibialis posterior muscle in short axis. The posterior tibialis nerve is noted on the right side of the screen. The left-sided images are now long axis, with the left side being proximal and the right side being distal. Back to axis, dynamic movement of the flexor communis reveals movement of the flexor communis muscle near the tibia. Now moving more posteriorly, we can see dynamic motion of the flexor pollicis longus. And finally, in long axis, we can see dynamic motion of the muscle in the middle, the flexor digitorum. Needle placement in the posterior compartment of the leg can be fraught with concern, especially in patients who have potential to bleed. I usually perform procedures using a short axis view, such as the one on the right, and I bring my needle in from the anterior aspect so that I can avoid the nerve and the neurovascular structures on the right side of the screen. The left side of the screen is demonstrating short axis evaluation of the hip adductors, and the right side is long axis evaluation. In short axis, the longus muscle is on the top, with the brevis muscle in the middle, and the Magnus muscle can be seen on the very bottom. This orientation can also be seen in the long axis view on the left side of the screen, with the longus, brevis, and Magnus. The longus, brevis, Magnus orientation can be seen medial to the neurovascular bundle at approximately the area of the femoral head when looking at the hip in short axis view. Once I find the smooth arc of femoral head in view in short axis, I move medially to find the neurovascular bundle seen here. The next step is to move from a short axis view from the neurovascular bundle even more medially to find the adductors. In this dynamic view, I'm moving laterally from the adductors to the neurovascular bundle and then medially again to find the longus brevis and Magnus. In short axis, the fascia between the layers of muscle is where you will find the superficial and the deep obturator nerves. Typically, this resembles a three-layer cake. Needle placement for botulinum injection or EMG typically is performed from the lateral to the medial, taking great care to avoid the neurovascular bundle. The arrow demonstrates longus, brevis, and magnus placement. This lateral to medial short axis view is also the way that I approach superficial and deep obturator nerve blocks. Another difficult muscle to find is the short head of the biceps femoris. This is the right short axis view of the lateral aspect of the knee at the condyle level. Noted is the biceps femoris long head muscle as well as the short head tendon, the lateral condyle. This is a short axis scan from proximal to distal and then again to proximal to show the short head of the biceps tendon here. And then as we go more proximally, you will see in short axis the formation of the deep short head of the biceps femoris. Again, in the short axis view with left being lateral, it would be appropriate to approach the short head from the lateral aspect. Before we get to the tibial nerve and the popliteal fossa, we're going to revisit the obturator nerve block. This is a still image of superior and deep obturator nerves, and now you can see the medication hypoechoic filling the superior obturator nerve. The tibial nerve can be hard to distinguish at the knee from surrounding tendons. Finding the deep popliteal artery can be a clue and milestone to help find the nerve, which typically is just superficial to it. In the short axis view, you can find the popliteal artery either as a hypoechoic circle or oval, or by using color Doppler. In this short axis dynamic view, you can see the hypoechoic popliteal artery bounding underneath the tibial nerve. I typically use short axis views first over the sciatic nerve distally and then proximal to distal views to follow the tibial nerve, the hypoechoic popliteal artery just underneath. This short axis view shows the tibial aspect of the nerve on the left separating from the smaller fibular nerve on the right. The lower left side of the screen exhibits the oval hypoechoic popliteal artery. When performing a tibial nerve block, I typically want to come medially to avoid the lateral fibular nerve. I also want to be able to get under the nerve and avoid the popliteal artery. These still pictures demonstrate placement of the needle under the nerve with hypoechoic fluid, and on the right side, placement of the needle at the 12 o'clock position with a total 360-degree flow pattern for the nerve block. Following the block, this is a short axis scan from distal to proximal, and you can see the needle on the underside of the nerve. There is 360-degree flow around the nerve. Those familiar with finding the fibular nerve and measuring it may find that finding the fibular nerve and then tracing proximally is a way to find the tibial nerve. For others, starting proximally and finding the large distal sciatic nerve and then using the heartbreak method to find the bifurcation is an easy method as well. Starting proximally in the back of the knee, we can find the sciatic nerve distally. In short axis view, we can move the transducer from proximally to distally, and in this case, we can follow the tibial nerve to the lateral aspect of the knee and of the condyle. In this heartbreak method, the tibial nerve is on the left side of the screen, and we're following the fibular nerve laterally over the lateral condyle seen at the bottom of the screen. Once the fibular nerve is seen at the level of the condyle, we can then evaluate the nerve continuing in short axis as it takes a J-shaped turn just under the fibular head across the fibular neck. In this short axis view, left is lateral, and you can see the bony shadow of the fibula with the nerve just above. Now the fibular head is seen with the nerve just below, above the fibular neck. The nerve is now taking its J-shaped swoop under the fibular head. The left side of the screen was lateral, but now it is turning to superior as the transducer follows the nerve in the J-shaped pathway. Finally, the transducer is moved to a long axis position to the body, just anterior to the fibular neck, to see both branches of the fibular nerve. The deep branch is more superior or left, and the superficial branch is to the right. Here's a proximal to distal short axis scan to show you how the images are gathered. On the left is the tip of the fibular head, near the nerve. With the transducer now in long axis to the body, you can see the nerve at the fibular neck, and now the nerve into the superficial and deep branches. I am now toggling in short axis to demonstrate the two branches. And finally, this is a distal to proximal scan of the fibular nerve. Here are some of the common nerve blocks for pain performed under ultrasound. We will not be going over the common carpal tunnel block, but you can see the needle above the nerve in this view and also below the nerve with 360-degree flow of medication. Morton's neuroma is usually at the third to fourth interspace. We usually do a short axis view above, and you can see the darkened hypoechoic nerve in the fourth interspace. Mulder's click sign is performed by squeezing the metatarsal heads and seeing if that neuroma has a click or a pop, which you can see at the fourth interspace on the right side of the screen. These still pictures demonstrate needle placement for nerve injection of steroid and anesthetic. Here the needle is just above the nerve in the sheath, and the dark hypoechoic fluid can be noted going around the nerve. Sural nerve blockade can be helpful in lateral foot and ankle pain. I prefer short axis views over the Achilles tendon, where you can see the sural nerve just over the lateral aspect of the tendon in these views. This is both short axis view on the left as well as a long axis view showing the tram track appearance of the sural nerve just above the tendon. I prefer short axis view with a transducer with lateral to medial placement of the medication just above and below the nerve, creating that anesthetic donut. The hypoechoic medication is being placed just above the nerve, slightly pressing it down, and in this view, the needle is at the 8 o'clock position with hypoechoic medication pressing the nerve up. Short axis view post-injection with removal of needle, showing medication completely surrounding the sural nerve. The lateral femoral cutaneous nerve can be seen just medial to the ASIS, usually superficial to the iliopsoas along the inguinal ligament. This is a left hip, and left of the screen is medial, and you can see the iliopsoas muscle, and just superficial and left near the bony shadow, you can see the honeycomb shape of the lateral femoral cutaneous nerve. This is a right hip, and noted is the ASIS on the left side of the screen, and needle placement is performed just above the nerve with hypoechoic fluid noted just medially and superficially.